Now,
Sure, sir.
you're going ahead with the imaging in heart failure. Again, you need a very good imaging to diagnose heart failure in the very early stage. And late stage is probably not very difficult, but for early stage of heart failure, it's quite difficult to diagnose. So imaging is a must, and for this, we'll hear from Dr. Dipanjan Bhattacharya.
Okay,
Dipanjan.
so good afternoon, everyone. Are my slides visible?
Yes, yes. Slideshow mode.
So I'm just going to the slideshow mode. Okay, so as we know, so my topic is imaging in heart failure. So as we know that imaging is the keystone for the diagnosis of heart failure, both in the early stage as well as the late stage. So this is the basic classification of heart failure which is now being followed based on the ejection fraction. More than 50% it's HFpEF, 40 to 49% is MREF, and below 40% is FREF. So first comes the our old friend, the echocardiogram. So this is the cornerstone of the heart failure patient evaluation, and it forms the first step. So the information we can get is the ejection fraction, any valve function abnormality, valvular pathologies, diastolic function, strain imaging, and assessment of the right and left-sided filling pressure assessment. So regarding the estimation of ejection fraction, this is the one which is most commonly used. This is the take mode, M mode, take mode which is used. And even more sensitive parameters are the AL method and Simpson's method, where we consider the entire LV, both in systole and diastole. And now with the newer machines, we have got the estimation of echo by the 3D EF, where we can get a 3D image of the LV, both in the apical four-chamber view and in the short axis views, and then we can get a 3D EF, similar to what is used in cardiac MRI. So next, coming to the estimation of filling pressure. So this is a very important slide. This forms the keystone for the diagnosis of heart failure. So if we see the image on the upper part of the screen, we can see that the IVC is collapsing. So this indicates that the CVP is normal. And if we see an IVC, which is as seen in the lower part of the screen, which is dilated, non-collapsing, with spontaneous echo contrast, this invariably tells that this patient is in heart failure. And this is what is used. So if we have a diameter less than 20 millimeters with more than 50% inspiratory collapse, the CVP is less than 5. Diameter less than 20 and less than 50% inspiratory collapse, the CVP is 10. Diameter more than 20 and less than 50% collapse, it's 15. And diameter more than 20 and no inspiratory collapse, it is 20. So this also reflects the mean right atrial pressure. So how do we estimate the left-sided filling pressures? So we have to go by the mitral E by A and E by E prime ratios. So if we follow this algorithm, that E by A is less than equal to 1, and if we find that the RA pressure is less than 10, we have a collapsing IVC, there is no PAH, and the LA is not dilated, and E by E prime is less than 14, so our wedge pressure is less than 15. However, if we find that E by A is more than 2, or E by A is between 1 to 2 with RA pressure more than 10, with evidence of pulmonary arterial hypertension, with dilated LA, and E by E prime more than 14, invariably the wedge pressure is elevated. So next, coming to how we see the valvular pathology. So echo is again the like gold standard which is being followed for diagnosis of valvular pathology. So here we can see a patient who has got moderate to severe AR. And here we can find a patient who has got some component of MS as well as moderate MR. So coming to TE, this gives an even clearer picture. Here we can see a patient who has got a flail AML with MR, and this is the 3D image where we can see both the aortic valve and the mitral valve, and we can clearly see the segment of the mitral valve which is prolapsing. So 3D gives an even better picture of the valves. Similarly, here is a patient who has got moderate to severe AR, and T gives much more better pictures, and as well as we can see the jet on 3D also. So this is again a patient who has got rheumatic severe MS. So here we can see that the leaflet is thickened and completely restricted. The LA is dilated with spontaneous echo contrast, and we can measure the mitral valve area even on 3D. So here the area is 0.46 indicating severe MS. So next, coming to strain imaging. So it's a sensitive indicator for subclinical disease. We can detect patients with heart failure even earlier. And we can diagnose patients who have got infiltrative cardiomyopathies as well as non-ischemic cardiomyopathies. We can give a better delineation of segmental dyskinesia and wall motion abnormalities. And we can also assess the postoperative reverse remodeling process. And in patients with LBBB, we can identify dysynchrony as well as modulate the response to CRT. So this is a patient who had HF, and we found that the strain was markedly reduced, and the bullseye plot showed a cherry on top appearance suggestive of cardiac amyloid. So without strain imaging, the diagnosis of restrictive cardiomyopathy with the suspected amyloid would have been entirely missed. And this is the pattern which we see in LBBB. So it has got these two distinct peaks, and it can be used to modulate the response of CRT and follow these patients. Again, this is a picture of Takotsubo cardiomyopathy, where we can find that the strain is preserved towards the base, and as we go towards the apex, it gets markedly reduced. So this is a patient who had ischemic cardiomyopathy post MI, and here we can see that the strain is globally reduced, and it can better delineate the wall motion abnormality as compared to a conventional 2T echo. So next coming to cardiac MRI, so we get an accurate measurement of ejection fraction. We get quantification of regurgitant jets. We get tissue characterization, and we also have the option of stress perfusion and strain imaging on MRI. So coming to the 2021 ESC guidelines, so they give a class 1 recommendation for in cardiac MRI in patients who have got poor echo windows, and if we are suspecting infiltrative diseases like Fabry disease, inflammatory disease, LV non-compaction, amyloid, sarcoid, and hemochromatosis. And it is a class 2A recommendation for imaging with LGE in patients with DCM to differentiate between ischemic and non-ischemic cardiomyopathy. So coming to this topic of LG, so it is the images are taken 10 to 30 minutes after the administration of gadolinium-based contrast agent, and areas which are injured, they have a delayed washout of the contrast. So here we can see, so first after the injection of contrast, we get a first pass perfusion. We see for any perfusion defects. Then we have the phase of early gadolinium enhancement, that is between 5 and 10 minutes, and then between 10 to 30 minutes, we have got the LG pictures. So based on the pattern of LG, so this is a picture just seen in all textbooks. So based on the LG pattern, we can tell what the patient has. So this is a patient who has got some endocardial LG, and here we have a patient who has got transmural LG. So next we have something called the T1 mapping and the ECV. So what happens is T1, it creates a pixelated map obtained by measuring the longitudinal relaxation time of the individual protons while they re-equilibrate following excitation with the radio frequency beam. So in the T1 values are elevated in patients who have got acute edema, acute infarction, inflammation, or there is an increase in the interstitial space, and it is reduced in conditions with lipid overload like Anderson-Fabry disease and lipomatous metaplasia and iron overload. And we also have a parameter called ECV. So if it is increased in cases with increased collagen deposition. So this is the chart between the native T1 values and the ECV. So as we can see, these are the subsets where the T1 values are increased more than 1200 and ECV also gets increased. That is in acute MI, tail amyloid, ATTR amyloid, and chronic MI. T2 imaging, again, it is the T2 relaxation times are increase in inflammation, that is myocarditis, sarcoidosis, and infarction. And T2 star imaging is a marker of iron overload. So if it is below 20, it is a predictor of heart failure. Next, coming to viability assessment by cardiac MRI. So the classic teaching is that if the scar is a transmural one, more than 50%, it is a non-viable part of the myocardium. So here are some clips. So here we can see, just 1 second. So here in this image, we can see that the LV is grossly dilated and there is global LV hypokinesia. So this is classical of typical DCM. So in this image, we can clearly see the hypertrophic pattern of the septum and the posterior wall, the septum more than the posterior wall, and it is a typical example of an hypertrophic cardiomyopathy. So here we have a patient who has got LV dysfunction, and we can see the transmural scar. So this is a case of ischemic cardiomyopathy post MI. And here in this patient, we can see that the RV is grossly dilated with increase in the trabecular conditions. So this is a case of ARVC. So this is again a case of the DCM where we can see that the LV is dilated with global LV hypokinesia. I'll just okay. So I'll just like rush to the important slides now. So coming to non-invasive imaging. So CT coronary angio is considered as a class 2 indication in patients with low to intermediate pretest probability for CAD or those with equivocal non-invasive uh, stress test. And invasive CAG is a class 1 recommendation in patients with angina. And in class 2B in patients with FRF with an intermediate to high risk pretest probability. So I'll just show one case which was uh, like really eye opener for us. So we had a 59-year-old female with recurrent heart failure admissions. She was diagnosed as a severe MR and was planned for MVR. So she was taken up for a coronary angiogram prior to her surgery. However, we were surprised that when we took her for invasive angiogram, the LMCA was not seen anywhere. And we found that the RCA was tortuous and it was giving collaterals to the LAD. So we did a CT coronary angiogram for her, and to our surprise, she turned out to be a case of Alcapa. We can see that the left coronary artery is arising from the pulmonary artery. So PET imaging is where we use the PET radiopharmaceutical and we measure the emitted photons. And the role in heart failure are ability assessment, diagnosis of inflammatory cardiomyopathies, the diagnosis of cardiac sarcoid and disease activity, and estimation of the chemotherapy related cardiotoxicity. So we for viability assessment, the patient has to be fasting and we have to give an oral glucose load to achieve a euglycemic state, and we have to ensure that the fatty acid metabolism is suppressed and the myocardium takes up glucose only. So this is how we differentiate between patients who have got a normal myocardium versus hibernating scar and stunned myocardium based on the perfusion and the FDG uptake. So this is an image where we get where we can see there is a perfusion metabolism mismatch. The areas which are having which are not having perfusion, as in here, they have a clear cut FDG uptake and metabolism. And here we have an example of a matched defect. The areas where the perfusion is absent, they also have a reduced metabolism. And for ATTR amyloid, the technetium maintained phosphate scan, it has got a sensitivity of 97% and specificity of 100%. So this is the heterogeneity score which is used, and this is a picture. Basically, we have to compare the uptake in the heart as compared to the uptake in the ribs. In Anderson Fabry disease, so this is an article which utilized the PET MRI fused imaging and found that that we can follow up the patients who are on enzyme replacement therapy using PET. And in cardiac sarcoid, this PET scan has got a sensitivity of 88%. It is even superior to cardiac MRI. And if there's a perfusion and metabolism abnormality, it is associated with a higher incidence of ventricular tachycardia and sudden cardiac death. So these are the stages which can be seen on the PET imaging. And we can see that post steroid therapy, there is a significant reduction of the FDG uptake. And this was a study which was presented in the HRS from India. And they found that the PET scan was much superior to cardiac MRI in diagnosing cardiac sarcoid, especially in the early stages. And in chemotherapy-induced cardiotoxicity, so these are the FDG molecule, the PET molecules which are used for identifying early chemotherapy-induced myocardial dysfunction, and it is still in the investigative phase. So in my take-home messages, I'd like to emphasize that multimodality imaging is essential for establishing the diagnosis of heart failure as well as for evaluating the cause of the same. Cardiac MRI provides tissue characterization and viability assessment, and PET is a new kid on the block in the field of heart failure. Thank you. And I apologize for the technical glitch.
It's okay. It happens sometimes. No problem.